I'm going to talk about our pulmonary outcomes at Maine Medical Center and what we have planned and what we've been doing to improve. It was very interesting having Christine here. It's always interesting to hear what other centers are doing. And so the CF Foundation came up with these 7 goals for improvement. And this was the start of their quality improvement work that they started about 8 years ago now. And the goal was they're fairly general statements, but they wanted all patients to receive appropriate therapies for maintaining lung function. They wanted pulmonary exacerbations to be detected early and treated aggressively. They wanted patients to be returned to their full state of health whenever possible. That patients and their families will be full members of the healthcare team and that they would have open communication, be involved in care decisions, that everyone will be treated with respect and with attention to their preferences and values, that patients would have normal growth and function, be well-informed and active partners in reducing the spread of germs, be screened and managed aggressively for complications of disease, be supported by their CF Care Center with any decisions about transplant or end-of-life care, and also to have access to all appropriate therapies and support, regardless of race, age, education, or ability to pay. So these were lofty goals. But as you can see, these goals over this last period of time have made a dramatic difference. So over the past decade, these goals have really, as Ted Reed was saying, sometimes it seems so simple. So the quality improvement things that, oh, well, of course you're doing that. Well, sometimes you're not doing that. And you may come to work saying that you plan to do X, Y, and Z, but it may not actually be happening. And that's why the data is so useful to look at. Where's the, oh, here it is. So this is just looking at median predicted survival from 1987 to 2011. Dr. Sears already showed the slide, but I think it's just a wonderful slide to look at how much things have improved. So this is age in years. This is looking across the span, median predicted survival age, and we can see that from 1987 to 91 when this was 28. That round about here, when over the last decade, as the Cystic Fibrosis Foundation has focused so much on quality improvement, they have made a dramatic difference from like age 29 here up to over age 37 here at the end of this decade. So you wouldn't think this would be, many people were skeptical that this would make such a big difference, but it really has. So much of this quality improvement work through the CF Foundation came through the CF Patient Registry. So the CF Patient Registry was a registry that really is remarkable. There is no other disease in medicine that is tracked and followed and managed the way cystic fibrosis is. There's no other disease in medicine has a group like the CF Foundation that has a registry like this and that is so involved in not only fundraising but searching for a cure. So more than 40 years ago, this registry was developed to track the health of people with CF in the United States. The information in the registry allows us to do, initially they wanted to look at healthcare trends in CF, look at the most effective therapies that might be possible, to design new clinical trials for potential therapies, to compare the overall health of patients receiving care at different centers. Although initially the CF registry was all reported to centers anonymously. So you got your data back and you had no idea where you stood relative to anybody else. So the CF Foundation knew where you stood and they were able to track your care, but we didn't know where we stood and nobody else knew where we stood. So it was all quite anonymous. And it was also used to find areas where more improvement could be made in the health of those with CF. So from this, the registry now reports of 27,000 cystic fibrosis patients. Everyone at our center is in the CF registry. And most healthcare centers, that's the case. So all CF accredited centers, and that's 130 of those across the country. And it is very important for this data because this data, they thought it was going to be used for many projects, and it just keeps expanding. So it really, having a complete data set is really a remarkable thing, particularly over such a long period of time. And we were actually very incremental in this in northern New England because the data, the CF registry data used to be run by Dr. Jerry O'Connor, who is a wonderful epidemiologist at Dartmouth, who came to us 18 years ago with the Northern New England CF Centers, Vermont, Dartmouth, and Maine, and said, let's get together and form a consortium. And at the time, he was actually managing the CF registry for the CF Foundation. He was doing all the statistics, publishing all the data. And one of the big things he did, other than dramatically improving how this was reported, it used to be reported in sort of this screeds of just gray sheets of paper with numbers that were not very readable, and he created these beautiful graphs that you saw this morning that were very, very user-friendly and easy to understand. But the other thing that our group discovered, which is the other thing that Ted was bringing up this morning, is the variation in care between centers is very dramatic. And Dr. O'Connor really felt that that was the opportunity. The opportunity was to find out why there was variation in care and how could we narrow that variation, and how could centers with better outcomes perhaps learn from other centers. So the CF registry, the Harmony, Rena, along with Carrie Millard and along with Cindy Fletcher, they all are part of putting the CF registry data for our patients. It's put in every single clinic: height, weight, gender, CF mutations, pulmonary function, medication use, complications. There's a lot of information in there, and then there's it's all pulled together annually, and we get a program-specific report annually from the CF Foundation. And the outcomes are for the most recently completed registry. So then we recently got 2011 data. That's what you're seeing. And they compare our center to all the other centers across the country in 200 different categories. And these categories include nutrition and GI, pulmonary function and exacerbations, microbiology, guidelines for care, infant care, pulmonary therapies, complications, and airway clearance. So it's very comprehensive. And as I say, when I show this to other doctors in other specialties, they're just blown away, flabbergasted that we have this kind of data. This just doesn't exist. So one of the early quality improvement projects that we did at Maine Med over the last 6 years was looking at nutrition. So many of you may have been part of that. It was something that we called the 4+4 project. We knew that nutrition, I think it's in this slide, if you look at nutrition relative to FEV1 or to pulmonary function, that we know that patients, this is body mass index, and body mass index is what the parameter that we look for when we look at nutrition, that they showed that the better your body mass index, the better your lung function. So the goal for us was to have a body mass index of at least 50% because we knew that that would give better lung function. And we were able to have a dramatic improvement in this. What we did, I won't go into all the details, but we had patients come back every month for 6 months for very intensive nutritional care. And we were much more aggressive about putting in gastrostomy tubes early and aggressively than we had been. And our last data shows that now we have a very nice, our BMI data for patients aged 2 to 19 is very good nationally. And this just shows, this is a graph, our center is in the red here, so we're the red. And they also show us the 10 best centers across the country for BMI. And you can see that this is the year, so 2007, 2011, you can see that we really improved. Our BMI went from below average here to above average here and up, sort of approximating the 10 best centers in the country. And we actually won a QI award from the CF Foundation for that, which was very nice. They gave us a presentation in front of all the other centers at the meeting. So we were very happy about this. This really worked well. And we were also able to, this is the percent of patients who are less than the 50th percentile. In other words, the percent of patients who are too skinny, too thin. We were able to decrease that. So you can see here, 2007, we had 60% of our patients were below the 50th percentile, and now only 40% of them are. So big difference. So we went from being above average below the 50th percentile to being below average, which is exactly where we wanted to be. So we were very happy about that. So this is looking at lung function. And this is looking at lung function by age group. So this slide comes from the CF Foundation. And the goal of the reason why I'm showing this is to say that we know that in the age 6 to 17-year-old age group, so the childhood to adolescent age group, that we want to have normal to mild disease. So that's the green bar here. And we want as many patients as possible in that green bar. That's the goal. And the goal is to keep this green bar as high as possible when you get to the adult population. We know that there will be decline, we expect that, but we want as many people as we can get to be over in this green bar. And we want as few people as possible to be in the moderate bar. The goal is that when we send our patients to Dr. Zuckerman and Dr. Sears, they're all over here, because it's very hard for them to work in reverse. If somebody's already lost lung function, it's very hard for them to regain it. So we were, what we noticed with our FEV1 data was that it was not improving and not where we wanted it to be. So this is the 10 best centers here. This is 2007 to 2011. And you can see that our data here was below average and actually fell here in 2011, which we found very concerning. So it fell from the median FEV1 from 6 to 7 years, and we said that's FEV1 is how much you can blow out on that first second on spirometry, and it fell down to a median of 82%, whereas at the best centers the median is closer to 100%, and the average was somewhere in the mid-90s, low 90s. And this is showing it in that similar graph there, where each one of these blue squares is a center across the country. The green bar is the average, and this is showing where we were in 2011. So we were dismayed that our lung function was falling compared to the average, and we wanted to look at different factors that could affect lung function that we might be able to change. So we had done several projects to look at lung function in the past. We actually used ibuprofen when it first came out several years ago. We jumped on that bandwagon very, very early, and then we had a patient who had a GI bleed with ibuprofen, and we took them off it. Yeah. So we got chicken, and we took them off, and we said, oh no, you know, the GI bleed, and because CF physicians always worry about doing harm. You know, we never want to do any harm. Every therapy we give, there's always a risk benefit. And at that point, we knew there was a benefit, but it was very hard for us to really argue that the benefit was going to be worth the risk. We just weren't sure. So we said, we're going to wait. We're going to wait and see over time if more people start using this therapy and what the outcomes are. And I'll talk more about that. We also used the pulmonary exacerbation score. So similar to what they did in Ohio, we saw that data presented several times at the meeting. We brought back a similar type of score. We actually adapted it a bit for pediatrics because, as I said, that score is very, a bit more adult focused. But I think that score works more in bigger groups, as I said, where you're trying to narrow the variability that doctors are providing in care. It works less well in a smaller group. So we didn't see a lot of difference with that. We also developed a phone triage algorithm quite a while ago. So when our nurses take phone triage, they actually go down a scoring system to score the exacerbation and decide what the plan is of therapy. So we had done several things in the past, but pulmonary function is a tough one to improve. So looking at some of the other things, this is respiratory germs by age. So this is looking at age along the bottom here, and this is looking at the percent of people with CF with these organisms. So this is Staph aureus, which we say to patients are very common. 60% of patients under age 2, and then by the time they get to the teenage years, almost 80% have Staph aureus. Pseudomonas, 20% under age 2, and then almost by the time you get into the 20s and 30s, it's almost 80%. And then MRSA runs about 20% for most centers. B. cepacia runs about 4 or 5%. So we went through a process of looking at different things that might be affecting our data, our pulmonary data. So we wanted to know, are our cultures different at CF? Are our patients growing different types of cultures than across the country? But in general, that wasn't really true. And it hasn't been true all along. That really hasn't changed. We're very similar to national numbers. We have 36% of our patients under 18 have Pseudomonas. The average is 34. 2.6 have cepacia. The average is 2.6. 23% have Stenotrophomonas. We're slightly higher with that. 24% of MRSA. It's almost that average. So our culture results were very, very similar to national trends. And that will be important because if we had a very high, say we had 70% of our patients had Pseudomonas or 50% of our patients have MRSA, that would be very important because we'd have to say, whoa, what are we doing wrong? Is it our infection control? Why are so many more of our patients infected than at other centers? But we didn't find that that was the case. So this is looking at pulmonary therapies, similar to what Christine talked about earlier. And we also found very similar trends to national numbers. Albuterol, we use slightly less than average, 83% to 90. Dornase alpha, we're actually above average, 91% compared to 82. Toby, we're quite a bit above average, 83% compared to 65%. And these average numbers are for eligible patients, so it's not all patients. So like if they look at Toby, they're looking at patients who are over age 6, culture Pseudomonas. It has to be a patient who's eligible. So our use of Toby is high. Our use of Castim, which is ACE-3-NM, is also higher than average, 42%. Azithromycin, so that's that chronic therapy, that antibiotic that you give 3 times a week to decrease inflammation. We're also quite a bit above average for that, 95%. And our use of hypersonic saline is quite average compared to other centers. So we didn't seem to have much difference in trends in therapy, which is good. It would be bad if we looked and said, why is it that only half of our patients who should be on Toby are not on Toby? That would not be good. Or why is it that we are not offering Dornase and we're not offering hypertonic saline when these therapies are out there? But we didn't find that that was the case. So then one of the other parameters that we talked about before was compliance with care. So compliance with CF recommendations for care, that's what Cindy nags when she nags you all, and Karin nags you all to death about coming to clinic. So it's because the CF Foundation knows that there's a very strong correlation with the number of times you're seen in clinic. The closer you're followed, the better your outcome. And that you're seen at a CF center, obviously not a non-CF center. Like some patients are followed just in private pulmonary groups, and they know that you do better when you're followed at a CF center. So the CF Foundation recommends 4 visits a year, 1 CF culture and 1 PFT annually. And with this parameter, we actually fell somewhat. So in 2009, Cindy came up with the We Can Win project, which was a great project where patients got sort of a point system when they came to clinic, and they were put in a raffle, and we raffled off a Wii, and it really worked. People liked it, and they came to clinic, and the kids came, and we our compliance with recommendations for care was way above average, but now we dropped. I know. So this is age 6 to 17 years. These are patients who at our center are meeting compliance for the compliant with care recommendations. So you see, for the top centers, they have like 82 to 90% of their patients who are meeting these standards. And we were close to that. So here in 2009, we were almost there. We were actually at the same level as the top centers. And this year we fell to 65%, and we fell slightly below average. So that's, that definitely is concerning and something we would like to change. Yes.
And the first things they checked into are their things, like what meds are we applying and all that. This one is us. This is us. This isn't them. This is we're not going. We're not bringing our kids.
Right.
And maybe it's not us in this room because we're here, and maybe we're preaching to the choir here. But in our community, this is the behavior that's at home, the parents, the kids, and that's why we're here today, to try to be more focused on what we have to do to make outcomes improve.
Dr. Carins, do you see a difference in age? Easier to get kids not to school to clinic?
They don't break it down by age. And I don't think we've ever looked at it by age. Cindy, have you ever seen, do you think you've ever seen a trend with that?
My knee-jerk is that it just would be easier with younger kids as opposed to teenagers.
I think that's very true. Yes. And in the first year of life, we see patients so frequently. And particularly with newborn screening now, usually those parents are so focused and very compliant and really great about bringing their babies in. But yeah, like everything with CF, I think it changes with your stage of life and your child's stage of life, and and teenagers are so busy, it gets harder. But we would love your help with making this better. The We Can Win study was so simple. It was like, what did that tap into that helped? Did it just make the kids want to come? Did it make it that you felt like, it's almost, it's hard to say what it tapped into in all of you, but it tapped into something that you came more and people came more. Yes?
I know I'll bring my son to the clinic no matter what, but something as little as one of those stupid little toys that cost 50
Yep.
cents at the grocery store.
Help.
Bribing him, like,
Yes.
5 books.
Bribery works.
It
It does.
the kids to
Yeah. But Eddie, you are the people who could tell us that. So if you say, what will get my child there is X, we'll do that. Tell us what it is that, we have funds to do it. If you can think of ideas, anything, it helps.
Sometimes it's a matter of scheduling. So
Sure.
I put off 1 month, and the soonest I can get in is a month later into clinic, and then that's
Yeah.
thrown me off, so I only got 3 visits in 1 year, even
Yeah.
though we were going every 3 months.
Right.
But it was enough to throw the data off that visit got put into January
Yeah.
instead of December.
Yeah,
So there are things like
It's
that
true.
that happen.
And we haven't moved. It's not like parking's difficult or anything. I'm just reflecting on what
Yes.
would be the hassle.
Evening hours.
Yeah.
yeah, I know. And we have a challenge, you heard at Akron, the patients are an hour away, an hour, 2 hours tops. We have patients who come from a long distance, and that makes it harder. And we have weather issues and financial issues. We thought of gas cards, and we thought of, we've thought of different ways, but we asked for your suggestions today at the end of the day, and if there's any ideas you have, we love to hear them, because only what will work, I think. And this is just showing a similar thing on the same graph.
What
One more. Did you
yeah.
investigate physical therapy of just those practices? Did anything change there that might influence the outcomes?
Do we
Doesn't
look
sound
for
like-
pulmonary outcomes?
Yeah, use
Oh.
and compliance of PT, basically.
Um,
Methods, more vest use, less vest use, PEPs.
You know, it's interesting. I didn't bring up vest use in this, but we're very, very similar. It's like 80% of patients have a vest kind of thing. It's very, very on track. Yeah, and very similar to the data presented earlier. Yeah. Okay. And I think another thing that's very important is that sometimes looking at the registry sounds so simple, but sometimes you really often need to talk to people to really find out what it is about their practice pattern that's different. And I was so frustrated trying to make us better and what is it we're doing and how can we make ourselves better. One of the things I set up was a video conference call with Dr. Lahiri's group up at the University of Vermont. So we know them well. We've worked with them forever in the Northern New England Consortium, and they have very good data. And their center's a similar size, and they only have one doctor. Now they're going to have two, and a nurse practitioner, so it's very similar. So we talked to Dr. Lahiri for an hour on the phone, and we just kind of hammered at him. So what do you do when this happens, and when do you treat, and how long do you treat, and how long do you keep them in? And it was helpful. I mean, it was interesting. Their model definitely felt more aggressive. They followed people when their lung function dropped below 70-75%, they followed them like every 6 weeks. They saw them in the clinic frequently. They admitted early. I mean, once you had a course of oral therapy and you failed, you got admitted. They kept them in the hospital longer. So it was, but the interesting thing was we had to really sort of beat that out of him to get the answer, because sometimes the data just only tell you so much. Our cultures were similar to national averages. Our pulmonary therapies were similar. Our compliance to therapy could be improved in the last couple of years. So pulmonary exacerbations. So we wanted to look at, is that a place where we could be different? So we looked at the slides that show us median duration of IV antibiotic therapy. How long was our median hospital stay compared to other centers? What was our percentage of total treatment in the hospital? And ibuprofen, should we be using that? So this looks at the median total duration of IV antibiotic therapy. So this, unfortunately, it's hospital and home IV, so it's all lumped together. And this is, the data I'm talking about is all mostly pediatrics. I didn't go over the adult data for Maine Med today. And unfortunately, Dr. Zuckerman's not here today because the Vertex research meeting is today for the Vertex study, so he had to be at that. So this is looking from 2007 to 2011. So you can see that our number is the red, and our median total duration of IV antibiotic therapy is lower than average. And in 2010, it was quite a bit lower. And even now, it's back to similar, close to average, but still, a little bit on the lower side as far as how long we're treating people for a total length of hospital and home IV care.
So we can't assume that just we had a period of health during that time.
The optimist, always optimist. I don't know. It's hard to say what that,
That's a 50% difference at the low point.
Yeah.
50% to get back to that.
And we didn't change our practice here. It wasn't like we said, let's start treating people for 10 days instead of 14. But we definitely somehow our median dropped, the length of time we were treating people. And this is looking at the same on that different format, just showing that we dropped, like we were over below the average, and we were further over to the right here, which is not, which is just showing that we have a shorter length of time. And this is showing the total treatment duration in the hospital. In other words, how long were you in the hospital for your IV? And it shows that we're also below average. So the average here, so this was percent of total treatment in the hospital. The average was 80%. It doesn't show you what the best centers did on this graph, but it shows you that 80% of the patients did their total treatment duration in the hospital, and ours was less than that. Ours was only closer to 70%. And this is showing, it's similar, that percent of treatment in the hospital. So this is showing that we started using a lot more home IV. So we weren't keeping people in the hospitals often. And I think, we steadily moved to bringing people in the hospital maybe for 2 days, getting their lines and getting their therapies and sending them home. And we've fallen below the average for total treatment care in the hospital. And there isn't a lot of data to show that. It's very hard to prove that centers that keep people in the hospital have better outcome. It's just there's so many different variables. But when you talk to centers who use much less home IV, they will say to you, of course we keep them in the hospital. Of course they get better in the hospital. They're resting, we're observing them, we're making them run on a treadmill every day, we're forcing them to do chest PT three times a day, we're tracking their nutrition, we're looking at their cultures, we're tracking their FEV1. What do you mean they're going to get as well at home? Of course they won't. So they feel very strongly that they should be in the hospital. And so it's somewhat controversial.
I wonder, just at the audience, like when we have our IV episodes and we go home, we never miss the meds. But I'll tell you, the PT.
Yeah, everybody
not as
does.
easy.
Yeah.
Not as easy because.
Yeah.
Yeah. Well, yeah, we're going regular when we're supposed to be kind of twice as much, and that I think that's my observation. Just one person, but.
I think that's kind of part of the art of what you guys do. That's how I look at it. The empirical data isn't there to say it's better to send somebody home or not. In some circumstances, it's going to be better for them to be in the hospital, and that's some of the unspoken stuff you guys probably have to read in. Unfortunately, sometimes is these parents aren't usually as compliant, maybe in a non-judgment way. Maybe it's because they work weird hours and stuff like that. But these probably are, and they have. So I think you just have to always be making that judgment, as long as you don't have the empirical data to say which is better.
But it reminds me of Jerry O'Connor that I was talking about. He had all these wonderful sayings, and one of his best sayings was, nobody comes to work every day wanting to do a lousy job. Everybody starts off wanting to do a great job. And I don't think people go home on home IV wanting to do a lousy job. They all think they're gonna do chest PT 3 times a day and get on the treadmill, and just like we all think we're gonna exercise and eat more fruit and eat more, it's just that with all good intentions, I think when you get home, it's just so hard. And kids they're doing homework, you're doing laundry, you're making dinner, you're taking care of other children. It makes it very hard.
And I'll speak to this because
Yeah.
you know I'm the worst
I know.
critic. Because when we were in recently, I was so adamant that that my daughter be released after a few days. We ate better when we're home. We're very regimented about exercise. My daughter plays, 1 to 2 sports, 1 year round, and has 3 practices, a week. And, she can't exercise with the IV line, and she can't sleep with the nurses and the IV beeping all the time. Everything was disrupted. So my thought was, well, how is she going to get better in here? We are pretty regimented about doing PT twice a day and all of that. But the one thing that I did find, so I did kind of turn around a bit, was when you said to my husband, but she's flat on her back. There's no place for her to go. And we do run from practice to here to there.
Right.
And she did have 8 days of just having to be in one spot. And just from a pure rest standpoint,
Right.
I thought, you know what, this does make sense. Did I want to go home after a week and not stay for 2 weeks? Yes. And luckily we were able to do some therapy at home for a week. But I see the effect now, and she's so strong and so healthy from that. And I think that from the first time you did it, when we were released after 2 days, I see that she's stronger and better for resting, being in the hospital for that 8-day stint, just
Yeah.
purely resting.
And it's interesting, now that we've been doing this more over the last few months, many families who were, somewhat resistant, like, you want me to stay? And I would say, well, you have to stay at least until I see your lung function get better. I need to see, you can't just, and some of them have gone to lung functions that they haven't been at in 2 years. I mean, they've been ending up at the end of, 2 weeks, their lung functions are in the 90s, and they've been hovering in the 75, 82, and all of a sudden they're like, oh my goodness, we've never been this high. And then we've seen other ones who've stayed in for a week, their lung function's gone super high, and then they went home and we did a follow-up and we saw them 2 weeks after they were home and they fell way down again. And we're like, what happened? You've only been home for 10 days. So, and we know what happened. That what happened was it was very hard for them to keep all that up. So I think there is something to be said for that rest. There definitely is something to be said for it. So when we look at pulmonary exacerbation treatment, compared to national trends, our total duration in the hospital has fallen. It's less than average. Our total duration of IV is less. 7 to 9 days, average was 14, and our length of stay in the hospital was 6, and the average was 11. So how could we improve our function at MMC? So we felt that we wanted to see if we could use a more aggressive model to treat pulmonary functions. We wanted to consider ibuprofen again. And I spent a 1-hour taxi ride with Nate, who's the director at was the director at Christine Centers, where all he talked to me about was ibuprofen and how much he loves it. So it really made me think, I think we should go back and look at ibuprofen again. And I know that several of the centers there's a couple of centers in New England that use it, and their data is very good. So how can we improve patient compliance to visits? And then I'm sure all of you are aware that the CF Foundation has had this intensive focus on infection control recently. So our goal was how could we intensify infection control practices to minimize cross-infection? How could we bring in more infectious disease specialists? We have new staff who have joined, new infectious disease doctors that are very interested in CF. And how could we bring the Barbara Bush staff on the inpatient floor to be part of our improvement efforts? So what we decided to do was, looking at pulmonary exacerbations, we wanted to make sure that people resolve. So when we put them on an oral therapy, we felt like we wanted to make sure that they go back to baseline, because we're finding that people were getting put on an oral therapy, then we were seeing them in we were seeing them in clinic maybe 2 months later, and they never really had picked their pulmonary function back up. And then we were also finding other people that when we looked, we said, oh, good Lord, this person's been on oral therapy every month for the last 4 months. That's not right. That's too, why are they getting sick that often? We also wanted to consider hospitalization after someone had had oral therapy one time if their symptoms didn't resolve. We wanted to consider using bronchoscopy for more patients who are symptomatic to make sure that we weren't missing anything on the culture. And we also wanted to more intensively look at the role of sinus disease. Could we be missing sinus disease that could require surgery that we could be more aggressively treating?
Because it harbors bacteria?
Yeah, harbors bacteria and constantly sort of seeds the lung, and sometimes doesn't get better with IV antibiotic therapy. You need to actually go in and drain it. Yeah, kind of roto-rooter.
Sinus one.
Sorry?
You're talking about the sinus.
Yeah.
My granddaughter, I raised her, my granddaughter, she's 4.5, and she went from October, November, December on antibiotics, and the minute it stopped, the green would just go, the minute it stopped, then it would go. And they considered, the last time they saw her at the clinic, they were gonna send her up here because you have someone that does I don't know, they go up with this, they widen it and make
Right.
it so drain, I don't know, I knew what she meant, but, if that final batch of antibiotics had not worked, then she was coming up here to have that done, because it would help it drain better. She said the infection gets up in there, and where it's so moist, it just stays there, and it's
Right.
like one of the ugliest ones to kill. And praise the January, it worked, the last batch worked, and she didn't have to come up. But that was the next step they were gonna do, so I was interested in that, because I hadn't known about that before.
Yeah.
So, and they do that only here, right? Because she goes to Vanguard clinics. They do
No,
that.
I mean, the main pediatric doctor that we use is Dr. Makritz and Dr. Murray, because they both do a lot of pediatrics and they're very familiar with CF. But particularly in adolescent patients, there are other doctors throughout the state, ENT doctors who will do it.
Well, I
Yeah.
just know not that they want to send them, but that's the only place they can place it.
Yeah.
They
Yeah.
don't know, so.
I mean, it's not a particularly new or innovative procedure. They're really just going in and scraping out the sinuses and letting them
Well, this
drain.
lady, she's only 4.5, it was the first time it happened.
It's unusual when they're bright and younger.
Go away, so.
Yeah. So now we're considering ENT referral for sinus disease for patients when they come in the hospital. And there's a special CAT scan that ear, nose, and throat doctors can do to get a very detailed look at the sinuses. So we're doing those more often with Dr. Murray's guidance. And we are encouraging more in hospital stays until your FEV1 improves. And for some patients, we're actually, we're keeping them in the whole time, even when their FEV1 improves. They know they're doing better and they're happy to stay and just complete the whole course. So we feel we can monitor their pulmonary function much more closely, make sure they're getting chest PT, make sure they run on the treadmill. We're trying to create an FEV1 goal for the admission so that there really is a goal for what our plan is. So if you come in, we're trying to look at your old FEV1. So if your FEV1s have been in the mid-70s all year, but at the end of last year they were in the mid-80s. So we're saying, okay, by the end of this admission, we want you at least in the mid-80s. So we kind of have a goal in mind for what we're trying to achieve, a number goal. And we're also reevaluating our antibiotic therapy in 5 days if there's no improvement. And we do, as I said, there's an infectious disease specialist who's been kind of more involved with us with this, and she's actually creating algorithms for treatment care with antibiotics. In other words, you come in on this organism. She came from Johns Hopkins where they did this in their center. Then you go on this therapy. If that doesn't work, you go on this therapy. So she's creating it as an algorithm, which I think will be great. And we're trying to see all patients 1 month after the discharge from the hospital and clinic. So this is how we plotted this out. You probably can't see this in the back. But the patients call to triage either in the hospital, so they call the nurses, or they call Dr. Mello or Mary Ellen or I on the weekends. We put an encounter into our EPIC chart. We send a message to Cindy Fletcher and Karen Wild, our secretary, saying, I started so-and-so on oral antibiotics. They're going to need a follow-up in 3 weeks. And then in 3 weeks, Cindy calls the patient and says, we saw you were started on antibiotic therapy. We want to know how you're doing. You're supposed to come back in clinic so we can check you. The same thing happens if they have a sick visit in clinic. The same note is sent to Cindy or Karen. And then if they're still symptomatic, then we say, okay, you need to come back into clinic and we're going to consider admission, consider a consult with ear, nose, and throat. If you're not improving, change your antibiotics, consider a BAL culture with bronchoscopy, and also defining what we're calling a pulmonary exacerbation. So we've been doing this now for about 3 months.
Dr. Carins D.O,
Yeah.
highly encouraging the patient come in if they're well after their course of oral antibiotics.
Well, that's a big question. So that's a tough one. And Cindy said, go ahead. Cindy's concern is also that they come back and then they don't come for their quarterly visit. That's her concern. So Cindy, if you want to.
We were a little tricky in the algorithm, which our script just showed where it said Cindy calls you at the end of 2 weeks to see how you're doing. When we tried that initially, but everyone didn't want to come back to clinic because when I
They were
called,
fine.
they were doing much better. And so once you come to clinic and you're feeling really well,
Right.
that's a hard sell. So we took the Cindy calls at 3 weeks out and we put in an appointment at 3 weeks. And if you don't come to that appointment, then Cindy calls. We're really hoping to see like a 3 week call appointment.
Yeah.
And it seems to have worked better. And we've actually
Right.
been doing this for 6
God, has it been that long? Wow. I guess it is. Yeah, it was January. Yeah.
We're going through that process now. We got the call.
Right.
We got the appointment.
What do we do?
It's next week. But
Yeah.
who's the best judge of how you'll find out next week? Patient can't do it.
That's I think that's tough. And I think with a younger baby, it's probably easier because you can say, oh, they've stopped coughing, they look fine. But I think with a teenager, it can be hard. Maybe their FEV1 didn't get back to its optimal number. And that was our goal, was to make sure that they truly got back to their optimal number, even though they kind of said they felt fine. So, but we struggle with that a bit. And we don't want it also to cut into their quarterly visit, so they stop coming to CF clinic and they're just coming on, say, a Tuesday and seeing Mary Ellen for a quick checkup. That wouldn't be good if they end up missing CF clinic. So, but give us your feedback on this. It's very helpful. So that was pulmonary function. Any questions about that? Any? Yes, go ahead.
I'm going to phrase this. One variable in difference in outcomes may be maybe something you guys looked at with respiratory therapy and people properly disinfecting equipment.
Yep.
You're reinfecting themselves.
Yeah, that's interesting. We've never actually, we haven't sort of done a patient survey of, I don't think ever, of disinfecting equipment. It certainly hasn't shown up in our microbiology, that people have different rates, but that would be a good QI project. We could look at that. We have cards that we give out how to disinfect equipment, but that would be interesting, yeah. Yes?
That's a strain on the family.
Oh, it
It's
is.
a lot.
Huge
Or you
strain.
don't have enough, and
Well, just use that one again.
So important, but it is a strain, yeah.
You want to.
Okay, so infection control. So we had numerous meetings with the staff at the hospital because we wanted to revamp, change our infection control protocol, make sure that it was what we wanted it to be, have it a bit more in line with the adult protocol at the hospital, which was slightly different. We didn't want people going over to the adult floors and saying, what do you mean I can't do this? And so we just wanted it all to be a bit more